Executive Director of the California Telehealth Resource Center, will be recording today's session. We find that a lot of our participants and those who access our resources will seek out this information asynchronously. So you will find this content available on our YouTube page after the session is completed, and we will be promoting it as we go through. So I'm going to hand it off to Aislinn Taylor to introduce herself with some housekeeping items, and then I will take back the steering wheel before handing off to Dr. Flannery.
Okay, awesome. All right, well, thank you for being here. So today we're going to be covering success and sustainability, talking about genetic services offered via telehealth, really exciting. Couple reminders for today. As always, we are recording today's session, so please know we are going to have this available on our YouTube for those that are unable to join or would like to rewatch today's session. And please use your chat and ask your questions throughout today's session. Last reminder, as usual for CTRC, we are here to share information. There is no relevant financial interest or arrangement with any products or services that may be mentioned in the presentation today. We are, as usual, wonderfully funded by HRSA's Office for the Advancement of Telehealth and the HCI, California State Office of Rural Health. So we are here to share information and education. So we have to introduce.
Great. So Dr. Flannery, before you start, for our listeners, both synchronous and asynchronous, I want to make sure that folks are aware that Dr. Flannery has been a leader in the arena of telegenetics nationally and has played a key role in the advancements not only of telegenetics, but telehealth more generally. He was a key physician leader when he was at ACMG, working with the American Medical Association to revise and update their policy on telehealth, predating the pandemic several years. He also was consulted by the National Quality Forum with regard to telehealth and quality measures in that arena. And he has been an innovator as well in the field. And so we are really delighted to have you here, Dr. Flannery, to talk about telegenetics. I've shared before, I have a personal journey and account of how telegenetics could have helped my family if it were available. And so we are really happy to have you here. So with that, I'm going to hand it over to you.
Great, thank you. It's always happy to talk about this stuff. Now, I was going to share my screen with my slides. Should I do that?
Yes, David, you are now welcome to share your screen.
Okay. Let's go ahead and share the screen. Go to presentation mode. Whoops. Come on, there we go. There we go. All right. So yes, the official title at Cleveland Clinic is Director of Telegenetics and Digital Genetics. And it's the Center for Personalized Genetic Healthcare. And genetics is becoming more important in healthcare. You remember back when President Obama announced the Precision Medicine Initiative. And this is just a slide showing the increasing demand for genetic testing. And implementing precision medicine is a challenge because there have been many studies done that showed that, well, a large percentage of physicians think genomics will impact their practice. Very few actually felt they knew enough to actually implement genomics clinically. So then we had this issue of the genetics workforce in the United States is quite small. There's only 1,600 MD clinical geneticists. There are about 5,000 genetic counselors. That's a very small workforce. Okay, why is it not moving forward? Okay, maybe it'll go forward now. Nope. Okay, something. it's great, but I want to go forward. What is it doing?
David, that might be on your computer. Do we have a version?
Yeah, I'm happy to take over
No,
sharing if you'd like.
It worked fine when we tested it out in the.
You may need to exit presenter mode and then manually click the next slide. Should be a transition setting.
Okay, so our Cleveland Clinic Center for Personalized Healthcare is one of the largest clinical services in the country. And every time we add additional geneticists or counselors, our schedules fill up, which means there's still an unmet demand. Now, primary care practices won't be as impressed, but for genetics, we saw 1,000 patient encounters last year, which is a huge number compared to many other genetic programs. This is our current staffing. We have 11 MD geneticists. Several of them are certified in other specialties in addition to genetics. And we have 25 genetic counselors, and they're on teams that are subspecialized in cancer, cardiovascular, general, ophthalmic, prenatal, renal. We've actually recently added hematologic and immunologic genetics. We have one pharmacist who is a PharmD who's got a PhD in genetics, and so she's our pharmacogenomics expert. And so I was hired at Cleveland Clinic to help transform genetic services to increase access. So the vision was provide the right person, the right provider, the right way at the right time. And our prime directive at Cleveland Clinic for personalized genetic healthcare is that we want to ensure that all providers practice at the top of their license. What my vision came on board was to use telemedicine. And when we do telemedicine for genetics, we call it telemedicine. And I wanted to implement eConsults and use genetic counseling chatbots. So prior to the pandemic, we had a small number of regularly scheduled virtual clinics. And we had an MD geneticist who was doing a flipped model of providing services. She lived in Florida, and she was seeing patients in our on-campus clinic from her home, because this is before people were doing telemedicine to people's homes. So she was like a specialist side of the hospital, providing a service to the hospital. And we also did a smattering of telegenic consults to the NICUs at regional hospitals. But despite my efforts, our total virtual encounters in 2019 was 129. So I was like pushing this rock over this. And then, of course, quickly it flipped to all outpatient genetic services for virtual starting March 16th, 2020, a day that will live in infamy, because when we did that, we thought that by June we'd be back to normal. Little did we know. So this was showing counseling encounters beginning of the pandemic. So as you can see here, here's the virtual encounters, and this is the in-person encounter. So almost no in-person encounters up until June. And in June, they announced institutionally that they would want us to, if possible, see some patients in person as well. And also what happened at that point in time is that to this point, there was no out-of-pocket expense for a virtual visit. And so then, of course, once they were encouraging in person, they started charging, a copay for virtual visits as well. And so you could see that suppressed the number of virtual visits for genetic counselors till the winter of 2021, at which point in time, due to compliance concerns, we had been not charging Medicare patients for genetic counseling visits because they would have gotten an ABN. They would have been told they were going to have to pay $180 for a session. And so what happened was the compliance legal decided that instead of doing that and losing a lot of patients who had Medicare, who had cancer, for example, that there would be no charge for genetic counseling visits for anybody. And so we had an absolute beautiful test case here, because then there was no financial incentive for people to be seen in person or virtually. There's like essentially, and so as you can see, it's just bopped along. They kept a nice number of virtual visits. MDs had a similar pattern, although there's not as much effect about the issue of out of pocket. And then what's most important is what's happened to our service, as we've gotten past the pandemic. And we continue to have, high 40% percentage of our outpatient visits still being virtual. And for some of our specialties, prenatal genetics, virtually all of the prenatal counseling sessions are virtual, which is, great for patients. There's additional benefits for this because we have this hybrid model. In addition to the fact that we can see patients virtually or in person, we also have 4 MD geneticists, including myself, who work for Cleveland Clinic even after moving outside of Cleveland. And what we do is, like for instance, at the end of June, I went for a week to go in person and take in-house call to the hospital in Cleveland. And our other MD geneticists have done that as well. One of them moved from Cleveland to a town in between Detroit and Ann Arbor. And so he comes back to Cleveland to see patients in person and also do in-house call 4 days a month, as does our nephrology geneticist, whose partner got a job in Cincinnati, so she went to Cincinnati. And so she sees patients virtually, but comes up 1 week a month to see patients in person and do some call. And we had one MD geneticist who was working in Denver, Colorado area, and then her husband moved to Boca Raton, Florida, and so she's in Florida, but she's continuing to work for Cleveland Clinic. So these people didn't have to go and find a new job. They could continue working for us. And we have 3 genetic counselors who work exclusively now outside of Cleveland. And we're actually recruiting 3 more genetic counselors. And one of the attractions of the positions is they're all virtual. So apparently in the first week, we had 30-some applicants for one of those positions, so much so that HR sort of cut off accepting applications. So it's been very attractive for providers as well, and leads to good satisfaction. So another plan I had was an eConsults for genetics. eConsults are a form of storage service. They're typically provided to MD consultant and ask a specific question. The consultant reviews the patient data and answers the questions and makes recommendations back to the requesting provider, but it never encounters the patient unless there's a need. Many studies of other specialties show patients usually end up needing to see the specialist maybe 1 out of 4 times after the result of an eConsult. And eConsults are typically sent within the EHR. So, for example, in Cleveland Clinic, we use Epic, so we have eConsult templates built into, and so physician goes in and places an order for an eConsult to genetics. And there are CPT codes for this. It's interprofessional interconsultation. And this is one of the things that the Digital Medicine Payment Advisory Group that I was on actually created. Was there's a code for the provider requesting the eConsult. There's also a code for the consultant answering the eConsult. Cleveland Clinic, we've even added an extra benefit to it that the requesting provider can also, after getting the reply from the consultant, can also then go and click on another link and go and get CME credit for having read it upon the eConsult. So it's an extra incentive to people. And so we started offering Geneticist eConsults in October of 2019 because it took a while to build the templates and then to test them out. And providers in Ohio can now order this. We've built it so that only outpatient can be under an eConsult. So in other words, if a provider is in an inpatient context in Epic, the order is not findable. And so that was to make sure we didn't have people inappropriately ordering eConsults on patients who really should be seen in person. And then we built the playbook explaining the process and what reasons there would be. And this is the screenshot of the order for an eConsult. And so we built structured data fields so that we can do studies that data from all of this. And so it makes life easier for them. This is basically the template for them. And we said, and here's my question. And make sure they ask a question. And then this is the genetics response. And so it has just various data fields as well. And slow growth, it improves booster reminders about their availability in department newsletters and during huddles, different services, and actually made presentations at grand rounds for some specialties as well. Typically, it's about one per business day, although today I've already got 2 came in. And we have a team who respond to eConsults. So there's 3 of us who reply to eConsults. So we have an in-basket just for that. And for future eConsult services, we're setting up availability of eConsults to Cleveland Clinic providers outside of Ohio, because Cleveland Clinic has hospitals in Florida, they have a hospital in Las Vegas, and they have more challenging. We have hospitals outside of the country. We have a hospital in London, Abu Dhabi, and so that's a challenge. We're working on getting approval for genetic counselors to provide eConsult services. We encountered this challenge because of the way that CPD code described it. The legal office felt that it was physician to physician. And, they said, well, I said, actually, it's other qualified healthcare providers, typical thing for CPT. And that like our counselors, other qualified health providers. It's sort of like, well, it depends on payers if they think that. So we're still working on that to figure that out. Now, I mentioned this, but there's no income that comes from this because Medicare, for example, requires a provider who's going to order an eConsult to let the patient know they're requesting an eConsult and they may be getting charged. And the typical copay for that would be about $7. But typically, we notice that eConsult gets requested after providers just see the patient, and they're not going to go contact the patient and then do the eConsult request. So institutionally, there's no charge for eConsults. What happens is when you go through and you sign off on the eConsult, the provider who's requesting it, as well as the consultant, then go to charge entry. And in charge entry, you click on the number of minutes it took you to do it, and that generates a credit for RVUs for the providers. So that's a small benefit here. And then my favorite thing was developing chatbots for clinical genetics. You don't know what chatbots are. You encounter them on a website. So programs designed to simulate conversation with humans online. And of course, most commercial ones are just terrible. We have this one, quick answers, like shipping something. Healthcare chatbots are a little more complicated. They do various things. They can provide additional information to patients about their diagnosis, side effects, implications, et cetera. And then they also could be used to essentially triage patients to be directed to the correct type of care provider. And then a burgeoning area is digital therapeutics. For example, there's a number of different ones that do with different forms of psychotherapy. And the Woebot has a really neat icon, so that's why I put it here. I'm not endorsing Woebot over any of the ones. And then we could also use them to ask patients preliminary or screening questions so that doctors can use their time in the most efficient manner when caring for patients. And instead of having like a questionnaire with the chatbot, you develop a script and you can have branching logic. And so it can be more interactive. So the patient. And so we actually, one of our providers who started a undiagnosed disease clinic is submitting a grant. We're going to develop a chatbot to basically help get a lot more information from patients after they've been referred in order to determine if they actually do qualify to be seen, potentially have whole genome sequencing. And so that would be very good for him because right now he either has to go and review all kinds of records on patients, sometimes they're hard to find, or he just has the patient come into clinic and then finds out that it's just not, going to be a very productive thing for the patient or for him. Healthcare chatbots obviously need to be HIPAA compliant, need to be secure, and they need to be clinically validated. And so that's an important part of it. And they operate on a bot platform, so it's an online ecosystem where chatbots reside, where they can be deployed from. And for many chatbots, the platform includes a database of information which the bot uses to answer questions. So frequently there's like a bank of FAQs that they can pull data from. Chatbots can run on all devices, computers, laptops, smartphones, tablets. And a link to a chatbot can be sent to patients as a text message, a chart message, or in an email.
You've got mail.
Uses for genetic chatbots, pre-test education, counseling, or consent. We can use it to triage, and this is assessing risk for genetic predisposition. I'll describe one of our studies that did that. And some people have used it for returning results of negative and normal results of tests. The problem is that you need to make sure patients understand that a negative test doesn't eliminate risk and that kind of stuff. And so having a chatbot who do that and provide that interactive information and get a sense that the patient has understood it would certainly make life easier for genetic counselors who otherwise call patients and then spend time on the phone explaining that to them. This is an example that I was saying about wanting to be able to enable providers to practice higher on their license. For a counselor, it'd be better for them to, be counseling patients and help cope with things rather than returning results and making sure the patient understands. And then some institutions have been using it to facilitate cascade testing. So what happens is, if a patient gets seen and they're determined to have a genetic predisposition to, say, colon cancer. Standard practice is for the counselor, when they see the patient and explain that result to the patient, they then look at the patient's family tree and say, well, all of these people here are at risk for having the same genetic predisposition, and they really should know about this and know that they can contact a genetic center to have counseling and be tested. Typically, that's done by giving the patient a letter to share with their relatives. And we know studies that a small percentage of relatives end up getting counseling and testing. And so there was a presentation a couple years ago for the University of Virginia where they actually started giving patients a chatbot to share this information about the risk for their relatives and information about how to contact the genetic center and that sort of stuff. And then the patient could just share it either as a text message or email with their relatives. And they discovered they had a huge increased percentage of relatives who ended up having counseling and testing. So it shows the proof of concept is really good. And then we've had discussions with some of our people doing clinical trials about using chatbots for patient recruitment, getting consent, and then potentially for having patient-reported outcome data, which would be, really great. So far, we've customized a chatbot, a laboratory that does the proactive gene testing for executive health patients. And so this chatbot, then the link gets sent to any patient who is interested in having proactive gene testing. And so in advance of their visit to Cleveland Clinic Executive Health, they go interact with the chatbot. The chatbot uses algorithms to then determine, and it will say, well, you're actually at increased risk for, cancer predisposition. So you really don't need this, everyone, you don't need to need some target testing as well. And then that, or conversely, it shows they're they don't have any worrisome personal or family history. And so then the counselor who deals with executive health just goes into the portal, the dashboard where the bots reside, and you look and see upcoming patients who they've interacted with chatbot, and she can see the results. And so then she sends a my chart message to the patient and says, this is great. I'm placing an order for Dr. Flannery to sign for you to have the gene testing done here for your executive health visit. Or firstly, say, you really need to have genetic counseling visit when you were here for executive health, and I will set that up so we can have that. And we had a research project where a chatbot was developed from the laboratory, and it was developed to assess a patient's personal and family history to identify increased risk of Lynch syndrome with the cancer predisposition syndrome. And the algorithms would then, if they were increased risk, say, you're at increased risk. When you come for your routine colonoscopy, would you want to see a genetic counselor? And this was offered, chatbot link was offered to every patient who was coming in for routine screening colonoscopy over a several month period of time. And the uptake was not as high as one would have hoped, but it was, it was decent, and it was published. And we felt we probably could tweak it a little more and probably have some more free offer education to patients who were coming in for colonoscopy and perhaps have flyers and things. But the problem was that the company that developed the chatbot with was acquired by a laboratory in that laboratory basically wanted all the chatbots to be used for driving testing to their lab, and we want to have sort of testing be lab agnostic. And so this went by the wayside, but we may redevelop something like this. Now, this is a demonstration of the chatbot that was used. Oops, back up. Where's the link? Who's hiding? Okay, takes a while to load. Hopefully you'll be able to read this the font. Okay, see that? It is kind of small font. And so then this takes them through all the discussion of their history and personal history. And the key thing for developing a chatbot like this is developing your scripts and figuring out your branching logic. And so we newly implemented a chatbot for pharmacogenomic patients. The pharmacogenomic tests look at specific genes that are involved in metabolism of drugs. And some of these genes activity decreases the breakdown of medication, while some increase the breakdown of medication, so they can lead to therapeutic failure or side effects. And some of these genes activity is needed to convert a prodrug into an active drug. So like the coagulant that acts on platelets called gel. And so the use case was we have one PharmD, who's the PGX expert. And all patients referred for possible PGX testing need to have pre-test counseling / education. And she can't just see patients by herself. So an MD has to join these visits. I mean, she could do them virtually, but then an MD has to have time to do that as well. So we decided that a customized chatbot would be a scalable solution to deliver education and also document patient decision-making regarding testing. And so that way our team could effectively provide higher value service to patients. And once again, that's higher license. And so we got a grant, and we got an experienced healthcare cat company, and it was a company so we could make it lab agnostic. And so we had a team of 2 genetic counselors, the PharmD and myself, and we basically essentially recreated what our pre-test session patient is to develop the script, and then done that script. And then this shows the workflow now. What happens now is that patients who are referred for possible pharmacogenomic testing, the order comes in, and our genetic counseling assistants then will send a MyChart message to those patients, and they'll say, you've been referred by Dr. So-and-so for possible pharmacogenomic testing, and before retesting, you need to have education in informed decision-making about the testing. And we have several options for you. One is for you to be seen in person or virtually by our genomics team. Or you could have same information and same interaction virtually with the chatbot at no cost. And a significant fraction of patients choose the chatbot, which is really great. And so then I'll link the chatbot sent to the patient by MyChart message or email or a text. Then patients, complete the chat. And so we have, our GCA to monitor the dashboard, and they see who has completed their chat, and then gets sent to scheduling to schedule the patient for a visit. I'm sorry, if it gets sent to an order gets placed for me to sign to put in the test, and so then it gets shipped to the patient's home, and they do a cheek swab, pack it up, FedEx picks it up, it goes to the lab, and then when we get the test results, we contact the patient to set up a visit, either virtually or in person, to review the results with them. And this is sort of a screenshot of the PGX chatbot encounter. And it's not as clear as it could be, and but you just basically you saw the previous chatbot, and so it goes through. And in this one, there's branching logic because at a certain point, you can say like, would you like more information about pharmacogenomics in geriatric patients? We think this, like some more information. And then eventually it gets to the point where it says, do you feel that you've learned enough about this testing to make a decision about having testing done? And if they say yes, that then generates this green check, a portal that then leads the Jet counseling assistant going and placing a pending order for me to go sign off on for the patient. They say no, that then leads to the Jet counseling assistant sending a chart message to the patient, determining if they then actually need to talk to the pharmacogenomic expert. This is the dashboard. It shows the patients, and it shows chats that have been sent out. It shows whether the patients are actually have completed it or process or haven't opened it. And then we went live March 13th, 2023. So we're almost 1 year into it. And we just finished the first pass of going through all of the patients to date of collecting data. It took a while to get the IRB protocol and then get it approved and make some amendments to it after we tried data collection forms. And so we really can't give specific data, but in generalities, the company that works with us on this chatbot is just very impressive. It's one of the highest performing chatbots I've ever seen. There's like at least 50% of people offered the choice between the chatbot or a virtual or in-person pre-test encounter to take the chatbot. In ages, the oldest person we've had do the chatbot was in their 80s. So it's really quite remarkable. And the chatbot company is really excited because the completion rate is in the high 90%, which is just, tremendous. And, we just attribute the fact that we really, really, really worked the script and tested it out, a lot of times. And so now what's really great is that we have pharmacogenomic clinic Monday morning, Monday afternoon, and Tuesday morning. And so I do PGX clinic with the PharmD on Monday afternoons and Tuesday mornings. And at least 50% or more, actually Tuesday, 240 patients had done the chatbot. So they were being seen with test results and having a pre-test education session. And that's much more valuable for that encounter. And it actually is probably a cost saving to patients, because they don't have to co-pay for 2 visits. And then the company is really impressed with how high the patient satisfaction is with the chatbot encounter. Very, very high. So this is great. So we have future chatbot projects we're working on. We have one which we think is sort of be used by all of our specialty teams in genetics, because typically what happens is a patient comes in for genetic counseling, they're going to have testing. The counselor explains to the patient in advance, like, what this test is to be done. These tests don't necessarily come back like, typical, chemistry test of your blood, they can come back with different range of results: pathogenic, likely benign, variant of uncertain significance. And I try to explain that to the patient, at the time they're getting tested. But then frequently, when they call the patient with test results, especially if it's like a variant of uncertain significance, the patient has it's like a month ago. Basically, has sort of forgotten these things, and so it's not as efficient an encounter. And so we're going to develop a chatbot that will be post-visit reinforcement of understanding the possible types of results from genetic testing. So that when a patient, goes home, then one of the follow-up things they get is a link to this chatbot. And so they'll get a little booster, to help them remember this. And then the cascade test chatbot we want to develop because it's just really make life better for the counselors and more beneficial to families as well. And one I want to work on is a chatbot for intake assessment of patients with autism, because we could have parents do a interactive chatbot and provide much more information about the patient, and that could then help us algorithmically figure out, whether genetic testing would be productive in this patient and whether an actual visit with genetics would be useful. So it's more of triaging, which should be good. And then the latest project we're working on is trying to develop a tool that will screen patients for hypermobility. And so patients can just get a link. If we get the funding and get the product developed, patients will get a link and they be instructed to go through various maneuvers that test for flexibility. And it can then grade and score somebody as being whether they're hypermobile or not. And that can be very useful because that will help us in screening patients referred for potentially being seen for Ehlers-Danlos syndrome. And the famous saying, the best way to predict the future is to create it. And, we have the tools, we're limited by our imagination and regulation. So I just enjoy talking about this. I hope there's people who have some questions. I'm happy to talk.
Great. Thank you so much. We do have a few questions in the chat
Okay.
for you. So I'll start from the bottom and work our way up.
I'll stop sharing.
Okay, sounds great.
Otherwise, just big blank in the screen. Yeah, there we go.
Perfect. Wonderful. So I'm going to start from the bottom and work our way top. I see a couple questions first asking about the chat bot. So I see some familiar faces. We have Jonathan and Sylvia asking about the guardrails and kind of the effectiveness of the chatbot. Can you talk about the guardrails you have in place? Any solutions or situations where the AI is hallucinating or had incorrect responses?
It's not true AI, it's algorithm.
Okay.
It's not true AI.
So you,
all
right.
It's not, it's like,
so
it's not machine language learning, that kind of stuff. No.
all right, so it is different. So that was another question is how is it being used and trained? Is is it similar to an AI large language model?
No.
So Dr. Flannery, for our audience, I want to make sure both the ones who are synchronous, but those who are asynchronous, it's a rule-based model, meaning there's transparency and there is a human who is doing the programming.
Right. I mean, yes, it's like we just go like, okay, if you have a mother who had breast cancer before menopause, that increases your risk. There are actually scoring systems for this. And so, the algorithm then does the scoring according to what's known about the scoring system. and then similar things for colon cancer and that sort of stuff. So it's based on established things, not but our expert opinion leading to.
Yeah, so it's not machine learning where an algorithm is
Right.
consuming data, seeing patterns, and then
No.
putting an
No.
output.
Nope.
So that's really helpful. You identified, if I may, Aislinn, I'm going to jump in a couple of these items. I want to elaborate a little bit about the areas that you are applying the chatbot, and wondering, since you're seeing such a high level of success, is this unique to genetic, or is this, you're obviously a genetics expert, but do you see this as a clinician leader as an area where a chatbot could be applied in other areas of medicine where there are significant shortages of clinicians?
Oh, I'm sure there are. I just haven't thought about other specialties and about that. It's like I gave a presentation about this to our Cleveland Clinic telehealth advocates group. We have, every specialty has a telehealth advocate now. And interestingly, I didn't get a lot of questions about chatbots. So it's a matter like that. But I guess, like I say, like one of our providers who has the undiagnosed disease clinic, sort of had an aha moment. We said, maybe I could develop a chat for helping, get into these patients and determining that they actually would be a good candidate, et cetera. So it's a matter of that. Sometimes people just have to find a use case, and then all of a sudden, chat can do that. Yeah. Yeah, it was interesting because I thought that the folks in the telehealth advocates group would have thought that was interesting, but not a single question of chatbots. So we've got a ways to go.
So another follow-up related to chatbots is it available in multiple languages?
Not ours. One company we looked at is called Nuance. They got acquired by Microsoft, but Nuance actually had the capability of doing other languages once you got the script, and then you had the capability of getting it to be just totally auditory. Unfortunately, their price tag for doing a project with us was a little too high for us getting a grant. So yeah, the capacities are out there, but for us to get this translated into, say, another language, we would have to have, someone who's, a medical, translator. And then typically what you do with that, if you do something like this, you translate everything into, say Spanish, then you reverse translate back to English to make sure it comes back right. Because otherwise, there could be flaws that you didn't realize there in the way language is used in another language. So that would be a lot of work for us.
Got it. And then one more on the chatbot before switching gears to another topic, and that is you're identifying other use cases for chatbots. It sounds like all of these are in the context of an already established relationship. Did I misunderstand that? Meaning the
No.
patient already has an established relationship with the clinician. This is part of a progression in services that they would have received in any case.
Well, all of our patients are referred. We don't get many self-referred patients to genetics, which are where I guess where you're going. It is not something we would put like on our webpage. Patients like, hey, do you need to see a geneticist? I don't know if we would do that. I might have to. I could see all of our legal people and things about that. Just to get this chatbot for pharmacogenomics, we had to go through 5 levels of IT and patient experience people and others to go through and make sure everything was fine and dandy and not create problems. So can't see anything being direct to consumer anytime soon.
So that's actually a nice segue to one of the questions I had, which is for patient population that may not have an established clinician relationship already, has a family history of genetic disorders. So some of CTRC resources are also for patients. What is the front door for those patients in this scenario? Is it, your traditional brick and mortar and primary care, and then they go through the door of telehealth or their clinician eConsult?
Yeah. Well, it's interesting. At one point early on, I wanted to try some kind of to consumer genetic offering, and none of the genetic counselors wanted to do it because they were just concerned about being inundated with patients with 23andMe results and other things like that. So, I mean, I do think there's a future for direct consumer in genetics in some way, shape, or form. It's just a matter of figuring out how to think about that. It would certainly be better than Dr. Google for patients. Certainly much better. Right now, we actually are doing eConsults nationally for a company that provides especially eConsults to typically safety net health networks.
Oh, I was just going to ask you about that. So
Yeah.
you stole my thunders. Can you elaborate on that?
Well, it's a company called Rubicon MD, and they basically, have panels of specialists who do eConsult, and the, so a physician, in some safety net healthcare situation or FQHC, I guess, can then, just log into their account and go say, I want to get an eConsult from a, endocrinologist, and then they can go and fill out the request and structure as well. And then that request goes to specialists on the panel, and they get a notification that there's a eConsult request, and there's information about who the provider requesting it is, that you're blinded to that, and they're blinded to the fact who the specialist is. Although lately Rubicon has started advertising that their specialists are from various, great healthcare systems that talk about how good your choice is there. And there's no PHI. They spelled out any accidental PHI in the request. And then the response is educational. So it's like if a patient, walked into my office with whatever you describe, here would be my thoughts. And then we typically add some literature to it for them, emphasizing that it's educational. And, that's interesting. I'm not sure how much these health systems have to pay for access to this, but, it's an interesting model. There's a competing one from someplace, I can't remember, that I looked into that was doing genetics. The problem was, since we have a contract with Rubicon, there's a non-compete, so we can't go, to another person and do it as well. So I wasn't really able to go check that one out. But there's someone out there.
Well, this is fascinating. So we really appreciate you joining us today, Dr. Flannery. Thank you for your incredible decades of trailblazing leadership in this space and really taking us to the next frontier. We're excited to hear back from you as the chatbot results come in, and we'd love to feature them once they're made public.
Okay, sure.
In your learnings. So with that, I'm going to thank you and hand it over to Aislinn. Oh, you're on mute, Aislinn.
You're muted. You're still muted.
Thank you. Appreciate it. I know it's going to happen one day. All right. So just to share some upcoming events, our next webinars we have on the schedule for March. Later this month, we'll have another AI in digital health services webinar. This time it will be health equity across the AI life cycle. So definitely a great one you'll want to join. And then back in April, we will have organizational governance of AI. So great sessions to join if you're looking to learn more about that. So please join us. And then additionally, I will share, we have some in-person opportunities coming up. If you are in Central California or the Southern California area, you may want to join us for a really intensive hands-on workshop. These are going to be all about digital health services ranging from telehealth, eConsult, AI, and more. Please join us for a day of learning actionable a lot of stuff from, we have an assessment so you can kind of dive into your current state. You can learn a lot of best practices, get a reimbursement and policy update, some grant funding opportunities, really just some great opportunities to learn. So please join us and we hope to see you again. And I will just end it with a final thank you to our participants and to Dr. Flannery for joining us and sharing so much knowledge today. Thank you. We appreciate it.
Always
We'll see
happy.
you next one.
Then one question I have, and Sylvia
Yeah.
may thought about, I'm giving a talk next week at the ACMG meeting about changes coming in billing for virtual care. And one of the things I'm telling people about the new telehealth codes that are coming out for January 2025